So today we have a topic to discuss, that's acute coronary syndrome or ACS. First of all, we have to know what is acute coronary syndrome. So any event that leads to reduction of the myocardial oxygen supply, blood supply, that is called acute coronary syndrome. Okay, so there may be a reduction of the blood supply or there may be a mismatch between the need of the cardiac oxygen demand and the supply. There are mainly three diseases that encompasses acute coronary syndrome. One is acute MI, that consists of acute ST elevated MI and non-ST elevated MI. Another one is angina, unstable angina. So how would you differentiate that acute coronary syndrome from stable angina or other cardiac causes? So there are some clues regarding the chest pain. Central squeezing, pressuring that radiates to the throat, jaw and the arm. The patient may have some autonomic symptoms such as sweating, nausea, vomiting, fear of impending death, that is called angor enemy. The patient may have any syncope or the patient may have actual fall. So if a patient with this kind of history presenting to us, we have to think if this is a case of acute coronary syndrome. As I have mentioned, there are two main pathology behind this acute coronary syndrome. One can be myocardial necrosis and one due to reduction of the blood supply. So acute coronary syndrome, that is acute MI. Here a pre-existing atherosclerotic plaque there may cause any kind of erosion or dislodgement, and above this erosion or atherosclerotic plaque rupture there is platelet aggregation. This platelet aggregation may lead to partial or complete occlusion of the major arteries. If there is complete occlusion of the artery, it will lead to myocardial necrosis that will lead to ST elevation and other cardiac biomarker changes. Okay, and if there is occlusion of a minor artery or there is partial occlusion of a major artery, these will lead to unstable angina. So complete occlusion leading to myocardial necrosis, it is MI, myocardial infarction. And reduction of blood supply with partial occlusion of a major artery or complete occlusion of a minor artery, this is called unstable angina. Clinically, it is very hard to differentiate between acute MI and unstable angina. So we have encompassed these two under acute coronary syndrome. If a patient with this kind of chest pain and typical symptoms presents to us, we will go for an ECG immediately. So all of the patients of MI, will they present with central chest pain and a classic radiation? So no, there are some exceptions, especially in case of old diabetic patients. Old diabetic patients may come and say that I have an abdominal discomfort in the epigastric region or I have a chest discomfort, but it's not like typical central squeezing or radiation. But you will always suspect MI in case of an old diabetic patient who presents with the chest discomfort. Okay, then we'll go for the ECG. Now what are the changes in the ECG? So not only ST elevation is a marker of acute MI. There are some changes that come with time. One can be ST elevation. Second, there can be new onset left bundle branch block. With time, the ST elevation starts to minimize. What comes later? There may be loss of height of R wave, progressive loss of height of R wave. There may be T inversion. There may be T inversion, and then at the later stage there may be developing deep Q waves. Deep Q waves. So any kind of change in this ECG, if we are saying there are some ST depression, there are some T inversion and not classic ST elevated MI sign, still you can think that it may be a case of non-ST elevated MI or unstable angina. Then what we do? We order some cardiac biomarkers. Most commonly used one is troponin I. There are also some other biomarkers, that is myoglobin and creatinine kinase. What are these? Myoglobin and creatinine kinase. So we use the troponin I mostly. Troponin I starts to elevate in the blood in 3 to 6 hours and remains elevated for 2 to 3 days. Okay, so there are some cardiac biomarkers. Most commonly one is troponin I and another is myoglobin and creatinine kinase. Okay, so we are looking for the evidence of myocardial damage. Either it may be ST elevated MI or there will be subtle ECG changes, and then go for cardiac biomarkers. If there is ST elevation clean cut in the ECG, it is a case of ST elevated MI. Okay, if there is no ST elevation in the ECG, but later the cardiac markers came as positive, high titers. This indicates there is evidence of myocardial ischemia or necrosis. So it is a case of non-ST elevated MI. Okay, but there is no specific ECG changes. ECG changes are like T inversion or ST depression, and the cardiac biomarkers are somehow normal. This may be a case of unstable angina without the clinical evidence of biochemical evidence of any myocardial necrosis. So to diagnose the acute myocardial infarction, we need a clinical history and some biochemical evidence as well. That may be ECG changes and cardiac biomarker changes. Okay, so such a patient presenting to us, what we will do? We will look for any risk factors the patient has. So acute coronary syndrome has some risk factors. Some of these are modifiable, some of these are non-modifiable. The non-modifiable ones are increasing age, male gender, previous family history, or the patient having history of familial hypercholesterolemia. These are non-modifiable risk factors. And what are the modifiable risk factors? Lifestyle, sedentary lifestyle, patient is alcoholic, smoker, uncontrolled hypertension, uncontrolled diabetic, dyslipidemic. These things we can modify through the lifestyle modifications and good pharmacological management. So these are modifiable factors. Some are modifiable, some are non-modifiable risk factors. So what are the investigations we will do? To diagnose, we will do the ECG, cardiac biomarkers. We will also do the echo. Why we are doing the echocardiography? Sometimes there is thrombus occlusion we can see in the echo, or there is sometimes some complications that develop after acute myocardial infarction, that is acute mitral regurgitation, papillary muscle rupture, ventricular septum dissection or rupture. These changes we can see in the echocardiography. Okay, so we will do ECG, cardiac markers, echocardiography. If the patient is diabetic, we will do the RBS. We have to check the lipid level, so we will go for serum lipid profile. Then what other risk factors patient may present with? We will do a chest X-ray to find out if there is any signs of pulmonary edema. If there is any left ventricular hypertrophy, there may be cardiomegaly. Okay. What bedside investigations or examinations we will do? We will check if the patient has any hypotension or if the patient is in any cardiogenic shock. What is the pulse? Is there any pulses alternance? Okay. Then we go for the precordium. We look for the apical impulse. Is it is laterally displaced? There is signs of left ventricular hypertrophy due to uncontrolled hypertension or diffuse apical impulse. Okay, then we will look for any evidence of third heart sound that may indicate heart failure. Then we will check for the lung bases to see if there is any basal crepitations to find out the signs of acute left ventricular failure. We will look for the JVP if the JVP is raised. Pulse may be tachycardic or due to autonomic activation may be bradycardia as well. We can look for other signs that can give us a clue to the etiology. For example, xanthelasma. Xanthelasma above the eyes to look for any evidence of dyslipidemia. We can examine the peripheral pulses. Okay. We can check the bedside RBS also to look if there is any other evidence suggesting of any vascular pathology. Okay. So we are diagnosing a case as acute coronary syndrome. What next? So in acute coronary syndrome, the management goes like this. MONA, we say this is MONA. M for morphine, O for oxygenation, N for nitrates, A for antiplatelet or anticoagulant therapy. But in exam start like this. Oxygen therapy, needed for all? No. When the patient is dyspneic, showing you the signs of heart failure and the saturation of oxygen is below 94%, then we will go for the oxygen therapy. Otherwise we will not give it. Because excessive oxygen, if we are giving it to the patient, there may be oxygen mediated free radical injury, and these free radicals may cause more myocyte damage. So oxygen, but not in all patients. MONA, morphine. Morphine is given in all the patients because it is so severe chest pain that patient may think that I am dying any moment. So morphine. One of the important side effects of morphine is it can cause vomiting tendency. So always morphine with an antiemetic. Then nitrates. As the patient has ongoing angina-like chest pain, the nitrates acts as vasodilators, which relieves the chest pain. And A, antiplatelet and anticoagulant therapy. Okay. So most importantly, in type of professional examination viva, sir asks questions like this. You are an intern working in the emergency department, or you are a doctor working in any Upajala healthcare hospital. You have a patient who has presented with chest pain and the ECG shows changes suggestive of myocardial infarction. What will you do? So I will do the loading dose and refer the patient to coronary care unit. As there are very low sitting units in the Upajala Health Hospital, we do not have any coronary care unit there. So what this loading dose comprises? This loading dose comprises aspirin 300 mg, clopidogrel 300 mg and atorvastatin or lipid lowering drugs 80 mg. We will give this loading dose. If the saturation is less than 94%, start the oxygen, give the morphine and refer the patient to CCU. Okay, now you are working in the cardiology unit of Sylhet Osman Medical College, or you are working in the medicine department. It's not cardiology unit. What will you do? If in medicine department you are receiving such a patient, we will give the loading dose and we will transfer the patient to CCU. Now the next question, how you will transfer the patient to coronary care unit? Will the patient go with his attendant or go on by own? So no. Me as an attending doctor must accompany the patient all my way from medicine department to cardiology. Why? Because after myocardial infarction, patient is at a high risk of developing various types of arrhythmia. Most fatal one is ventricular fibrillation, ventricular tachycardia. So this patient may anytime go into cardiac arrest, and as a doctor you may need to give the basic life support and CPR. So what is the management? Giving the loading dose and taking the patient along with the attending doctor until he reaches the coronary care unit. Okay, question solved. But now the next question comes. If you are a doctor in the coronary care unit, now what you will do? So now I will take the history. The onset of chest pain is less than 120 minutes and primary coronary intervention is possible in my center. Then we will go for PCI. If the chest pain is in more than 120 minutes but within 12 hours, then we will go for thrombolysis. We will go for thrombolysis. Most preferred thrombolytic nowadays is tinecta plus reti+. Tinecta plus reti+. These are tissue plasminogen activators to lyse the thrombus. So if within 2 hours, 120 minutes, primary PCI, within 12 hours or PCI is not available in my center, I will go for the thrombolysis therapy. Okay, these are the primary management. Loading dose, morphine, nitrates, if possible PCI, if not possible thrombolysis. Primary management done. Now secondary prevention. Secondary prevention means one event has occurred, but now I would look and find out the reasons why this event occurred and modify. So there are some lifestyle changes. We'll ask the patient to follow a Mediterranean style diet that is rich in the fruits, vegetables, less content of refined carbohydrates. Okay, I'll advise the patient that after 3 to 4 weeks, when the patient is able to do some light physical activity, patient will walk 30 minutes every day for 5 days in a week. 30 minutes every day, 5 days in a week, regular aerobic exercise like walking. Okay, if patient is smoker, he must quit smoking. If he is an alcoholic, moderation of the alcohol consumption. Okay, then control of hypertension, control of diabetes, lipid lowering therapy to control the cholesterol level. What are the preferred drugs for this? Beta blocker, AC inhibitor. These are the drugs that reduces long-term cardiovascular mortality. Beta blocker, AC inhibitor. Okay, then lipid lowering therapy, high dose statins may be needed. High dose statins may be needed. As we know, which one is the bad cholesterol? LDL cholesterol. So our target is the lower the better. The lower the LDL cholesterol is, it is better for the patient for cardiovascular risk reduction. So beta blocker, AC inhibitor, lipid lowering therapy, and aspirin clopidogrel, that is the dual antiplatelet therapy. We give it to the patient. Dual antiplatelet therapy for secondary prevention. Okay. Now the patient is admitted in my ward. We will be observing the patient at least for 2 to 3 days for evidence of any complications. What are the complications we should look for? Some immediate complications that are arrhythmia, ventricular fibrillation, ventricular tachycardia, atrial fibrillation, atrial tachycardia, any kind of arrhythmia can develop in this patient, or the patient can develop acute left ventricular failure. There may be development of ventricular septal rupture, papillary muscle rupture that may lead to acute mitral regurgitation, cardiac shock, and the patient may collapse. So we have to attach the patient to the ECG and a blood pressure monitor every time for 2 to 3 days and have to follow up the patient if there is any sign of this kind of any emergency arising. Okay. What are the late complications that may develop? The patient may also develop some late complications like left ventricles may become very much dilated. There may be aneurysm formation. Okay, it means its shape may become very abnormal. There may be post-MI Dressler syndrome. Pericarditis may develop. These are somehow late complications of MI. And we also do some echocardiography to assess the left ventricular function after an acute myocardial infarction. If the ejection fraction is very much low, 30-35% or less than 30%, it may indicate the myocardium damage was very much extensive, and patients sometimes may need some extra treatment apart from all these things. What are these treatments? They may be cardiac resynchronization therapy. They may need cardiac resynchronization therapy. If the ventricular ejection fraction after an MI is less than 35% and the patient develops class 3 or class 4 NOHA heart failure. Okay, but we will not go for this immediately. Usually we go like 4 weeks later for this kind of cardiac resynchronization therapy. Okay, the patient is stable after 2 to 3 days, we'll give him discharge. Ask him to return to his normal activities after 2 to 3 weeks. Okay, but light activities. After 4 weeks, he can mobilize and go to normal driving. Okay. Then after this, we can do coronary angiogram to find out where the patient normally sees block. We say stenosis, how much stenosis or how much block there is. The patient can later also go for coronary angiography. Hope that helps. So what are the questions we're going to face in the viva for these patients? Okay. They may give you a typical scenario that 55 years old diabetic patient presented to you with chest discomfort. It may be also epigastric pain, because if you remember, the inferior surface of the heart is on the more or less epigastric region. So epigastric pain can also be a presentation of inferior MI. So the question will be, diabetic patient, hypertensive, non-hypertensive, presented to you with inferior epigastric pain or typical central chest pain. Now what you will do? Sir, I will go for ECG. So initial ECG may not always show the dynamic changes. The initial ECG is normal. Then what's your answer? Sir, I will go for serial ECG. After 30 minutes, I will repeat another ECG. If this ECG shows left bundle branch block, ST depression, T inversion, not necessarily always ST elevation. Okay, these subtle changes I will also think there will be a case of acute coronary syndrome. Send the cardiac biomarkers and start the loading dose and emergency treatment. If I am in periphery where no further treatment is available, I will refer the patient to coronary care unit after giving the loading dose. Within 120 minutes, go for PCI. If time after 3 to 4 hours and PCI is not available, go for thrombolysis. I will try to look for immediate complications or any later complications. I will find out the risk factors and give the treatment for the risk factors accordingly. Okay, now I am in the Select Adjustment Medical College in the medicine department. I need to transfer the patient to CCU. Will the patient go alone? No. I will accompany the patient with myself. Why? Because there may be any kind of severe arrhythmia developing any time. The patient may go to cardiac arrest and I may need to give the CPR. Okay, then I will transfer the patient to CCU. In CCU, if there is setting possible and patient presenting within 120 minutes, PCI. Setting is not possible, patient presenting later, thrombolysis. Okay, then some drugs for risk reduction. For further myocardial damage reduction, beta blocker, AC inhibitor, dual antiplatelet therapies. Okay, ongoing pain, angina, we can give for morphine and nitrates. In all patients, we will give oxygen? No. The patient with oxygen saturation less than 94% dyspneic, we will give the patient oxygen. If the patient developing signs of acute left ventricular failure, bilateral basal crepitation or auscultation of the lung piece, okay, then we can give high dose furosemide, that is loop diuretics. Okay, these questions may cover everything regarding to the MI in our viva and the clinical short topic settings. Another thing, if reading the ECG, can you say which territory is involved? It means in which lead we can say that, okay, this is anterior circulation, this is lateral MI, this is inferior MI. So in ECG we look for the ST segment elevation, okay, and there are some clues to find out which ST segment elevation indicates which surface MI. We'll talk about it after our ECG classes, okay?